the knee arthroplasty outcomes. We are having technical difficulties on this side, so if you notice anything's not working or you can't hear us, just please let us know. We are going to be using Nearpod today, so take note of this code. It'll be on the top right of every screen in case you guys want to log on. Our objectives for today are to review the relationship between obesity and arthritis, to assess the effects of obesity on joint arthroplasty outcomes, discuss the current options for weight loss and the implications for arthritis and joint arthroplasty, to analyze the evidence for bariatric surgery prior to joint arthroplasty, and then to explore alternatives to bariatric surgery. This is a brief outline of what we'll be discussing. We'll start out with some cases and background, and then move on to how obesity and bariatric surgery affect arthroplasty, the alternatives to this, and then revisit our cases at the end. So our first case is patient RG. He's a 60-year-old male who had left knee pain without injury for many years. He walks without any assistance and has tried gel injections before his presentation that did not help much. He has diabetes, his weight is 440 pounds, BMI 61. He has a non-ontologic gait of varus alignment, mild diffusion, pretty good range of motion, and is neurovascularly intact. These are his x-rays showing severe degenerative joint disease in the knee with a significant varus malalignment. He was initially prescribed exercises and advised to attempt to lose weight, and he actually joined Weight Watchers, and he attempted to use NSAIDs for pain relief. He followed back up 2 years later with continued pain, and hyaluronic acid injections were attempted at that time. His BMI had not changed significantly from his prior 61, but 2 years after that, although he did not have any symptomatic improvement, he lost 160 pounds on Weight Watchers and came in with a BMI of 42.8. So if everyone can log on to Nearpod, I'll pose a question of what do you think we should do with this guy? He's now BMI is 42.8. All right, so far, majority of people are saying that this guy is ready for his total knee. So we're going to come back to this as we go later. Next patient, MS, is a 72-year-old female presenting with right knee pain without any injury, has past medical history, hypertension, breast cancer, hepatitis, a DVT in the past, hypothyroidism, and a hiatal hernia. BMI is 56.7 at the time of presentation. Has the valgus alignment of the knee, mild diffusion, good range of motion. These are x-rays showing significant degenerative joint disease. And we initially started with conservative management, hyaluronic acid injections, exercises, advised on weight loss, and NSAIDs. A year later, she had multiple repeat injections without any further symptomatic relief. And she did have a recent gastric sleeve and lost 100 pounds prior to representing with us. And her BMI is now under 40. So again, what do you guys think? All right, Everyone wants to do a total knee. Let's move on to the next one. Patient JV is a 58-year-old female presenting with left knee pain without injury, wears a knee brace, walks with a cane, uses NSAIDs for relief, has hypertension, asthma, psoriasis, gastric bypass. BMI was 35 when she presented and has a valgus alignment, mild effusion, good range of motion. These are her x-rays, significant degenerative joint disease, particularly in the patellofemoral joint. She was given a steroid injection, advised on exercises and cane use. She also was advised on additional weight loss. 6 years later, she came back after multiple repeat injections of both steroid and hyaluronic acid without significant improvement. And now the other knee was starting to hurt as well. Unfortunately, she gained a significant amount of weight back despite her prior bariatric surgery because she had a stoma dehiscence. So she went from 35 to 42 in her BMI, and the insurance company would not approve a revision of her stoma. So what do you think we should do for this lady? So the majority here wants additional weight loss before we go to arthroplasty. And the last one, AR, is a 68-year-old male with bilateral knee pain for 20 years, worked for a moving company, uses a cane to ambulate, has hypertension and AFib on Coumadin. BMI is 49.5. He has a varus malalignment, mild effusion, good range of motion. These are his x-rays. Initially, conservative management was attempted with exercises and weight loss recommended. At 3 years, he had no symptomatic improvement, and his BMI only went up from 49 to 57. He's ambulating with a walker at that point. 5 years, he had no symptomatic improvement, but he did undergo a recent gastric bypass, and his BMI came down to 46. And his original was 49. Continues to use a walker at this point. So for him, I'll pose a different question. When would it be safe to operate on him? So we're all over the board here, but our most popular answers are BMI under 40 and either 6 or 12 months from the bariatric surgery. All right, so with all that in mind, we can get into our data. So a brief background. Obesity has been demonstrated many times to significantly impact the development of osteoarthritis. According to the CDC, you're 2 times more likely to be diagnosed with arthritis with a BMI over 30. And other studies have quoted this to be as high as 7 times more in the knee and 3 times more likely in the hip, with also an expected increase in BMI increase in osteoarthritis diagnosis as your BMI increases. There was a retrospective study conducted in Spain using a database of primary care records in 2016 to analyze the effects of BMI on osteoarthritis development. They identified nearly 2 million subjects over 40 years old that did not have the diagnosis of osteoarthritis and followed them for an average of 4.5 years to calculate the incidence of newly diagnosed osteoarthritis. Overweight, but for them was defined as BMI over 25, type 1 obesity was over 30, and type 2 obesity over 35. And they found that the overall incidence of osteoarthritis increased for each weight category, regardless of body site. However, the knee appeared to be particularly susceptible, with a nearly 5-fold increase in incidence over BMI 35 compared to 2-fold for the hip. The classic thinking in the relationship between weight and osteoarthritis is that increased loads lead to increased cartilage wear. This makes sense as hip contact forces have been shown to be 2 to 3 times body weight during walker and as high as 3 to 5 times for the knee. Additionally, altered gait patterns in obese individuals lead to changes in which the regions of articular cartilage experience maximal load, which could contribute to differential wear. However, there has been more recent evidence to suggest that this is not the whole story. Obesity has been associated with a chronic inflammatory state in which higher adipocyte mass leads to increased adipocytokine secretion that are thought to play a role in cartilage homeostasis. Leptin, which inhibits hunger, has been seen in higher concentrations in both the serum and synovial fluid of obese individuals and has been associated with an increased severity of osteoarthritis. And similarly, resistin, vispadin, lipocalcin-2, and apelin have been implicated in the potentiation of osteoarthritis in obese patients. So now we will go into the relationship of obesity and arthroplasty. A 2014 study out of the Mayo Clinic retrospectively analyzed their knee arthroplasty database from 2000 and 2008 and identified a trend towards increased BMI of knee arthroplasty patients during this time, which amounted to a 1.4 BMI increase in primary and 2.1 increase in revision arthroplasty patients. This was also accompanied by a 10% increase in the proportion of arthroplasty patients who were categorized as obese at the time of surgery. And by the end of the study period, the percentage of arthroplasties in obese patients was nearly double the percentage of obese patients in the general population. Similarly, in a 2019 study from China, they retrospectively analyzed their hip and knee arthroplasty database from 2006 to 2014 and identified a trend towards a larger proportion of both hip and knee arthroplasty patients being morbidly obese during this time period. During that time, they found that the proportion of knee patients with morbid obesity nearly tripled, and that for hip patients more than doubled. While the data from this graph in the prior slide are no longer current, the trends appear to be continuing in the same direction today. So as we perform more of these joint arthroplasties on obese and morbidly obese patients, it becomes more essential that we understand the associated impacts. Historically, the prevailing thought was that joint arthroplasty would promote weight loss by increased activity levels. Patients often even present to the office with the mindset that if they would be able to lose weight, they could rid themselves of their joint pain. Unfortunately, the literature has challenged this dogma. Numerous studies, including those by Heisel, Donovan, and Abu Rajab, have examined this belief and found that not only did patients not lose weight after arthroplasty, but on average, they gained weight. A review of thousands of joint arthroplasties by AS discovered that the majority of patients see no significant weight change postoperatively, but more patients gained than lost weight. While it's apparent that about 10% of patients will see significant weight loss following arthroplasty, this has been shown to be the least common outcome and definitely cannot be relied upon. While the historical hope was that arthroplasty in obese patients could be a cure for their obesity, it has instead been shown consistently to both increase short and long-term complications due to the increased technical difficulty and the higher rate of medical comorbidities in these patients. In the short term, obesity has been shown to increase the risk of surgical site infections, respiratory complications, dislocations, and hospital length of stay. And in the long term, obesity leads to increased polywear, implant loosening, early prosthesis failure, and need for revision surgery. These patients also report increased long-term pain and stability, as well as decreased quality of life scores. When performing a total joint arthroplasty, there are many additional approach and technique considerations in this patient population. Many surgeons will prefer to have a bariatric bed, a hover mattress, and long scalpels available. During the exposure, total knees require more soft tissue dissection and can make for a more difficult patella eversion. And total hips, a large pannus can interfere with the anterior approach, and deep wounds make for a difficult visualization and retraction during the case. And total knees, determining the proper alignment could be more challenging with a significant amount of soft tissue interference. For this reason, some surgeons will preferentially use computer guidance or navigation in these patients to achieve higher confidence in obtaining the right alignment. And then aside from the difficulty making the correct cuts in the total knee, positioning of the final implant in obese patients can require excessive effort to appropriately externally rotate the tibia and lateralize the femoral implant. And for that reason, obese patients have been shown to have a higher risk of postoperative malalignment. Similarly, for total hips, with a large pannus and abundant soft tissue, interference in the surgical field, obtaining the correct positioning of your implants could be a challenge. Increasing body weight also increases the stresses transmitted through the fixation interface. So while the literature is unclear regarding rates of aseptic loosening in obese patients, some surgeons will consider additional fixation in significantly overweight patients in an attempt to counteract those forces. In addition, the use of dual mobility designs and constrained liners have been used in an attempt to reduce the risk of dislocation. A 2020 meta-analysis and systematic review analyzed the results of 67 studies to assess the outcomes and complications in obese versus non-obese patients undergoing total hip. These were composed of 19 prospective, 39 retrospective, and 9 case control studies of total hip arthroplasty patients. That included nearly 600,000 obese and 1.6 million non-obese patients. The baseline characteristics were similar, except for obese patients being younger by about 3 years on average and being more likely to have diabetes. The obese patients here were found to be at higher risk for total complications, deep and superficial infections, dislocations, reoperations, revisions, and readmissions. However, there was no difference in thromboembolic events, periprosthetic fracture, aseptic loosening, or nerve palsies. The authors theorized that the obese group was no more likely to have the periprosthetic fracture or aseptic loosening due to their younger age at the time of surgery. The similar rates of thromboembolic events can at least in part be explained by the increased vigilance by surgeons in placing obese patients on anticoagulation medications. In a sub-analysis of the morbidly obese patients, this cohort was found to have similar complication profiles, but of an even greater magnitude. There's similarly no difference in the rates of thromboembolic events, periprosthetic fracture, or aseptic loosening. When analyzing their perioperative data, obese patients were found to have longer OR times and lengths of stay, and were more likely to be discharged to a rehab facility. Morbidly obese patients had even longer operative times and were even more likely to be discharged to a rehab facility. There was no difference in reported blood loss between obese and non-obese patients or the morbidly obese. The same group in 2021 analyzed the results of 91 studies for total knee arthroplasty. These were composed of 22 prospective, 54 retrospective, and 15 case control studies. And they had over 900,000 obese and 2.2 million non-obese patients. Similarly, the baseline characteristics were similar, except for the difference in age of 4 years and the obese group being more likely to have diabetes. Similar to the analysis of total hips, these obese total knee patients were found to be at higher risk for total complications, deep and superficial infection, revision, and readmission, but by smaller magnitudes than in the hip patient. Also similar to the hip patients, there was no difference in thromboembolic events, periprosthetic fracture, aseptic loosening, or nerve palsies. However, they also found no difference in hematomas or all-cause reoperations. When analyzing for the morbidly obese patients, they found a similar increase in rates of infection, revisions, and readmissions, but there was no increase in magnitude like we saw in the total hip group. More shocking was the lack of difference in the overall rate of complications in this morbidly obese group. There was similarly no differences in thromboembolic events, periprosthetic fracture, aseptic loosening, nerve palsies, hematomas, or reoperations. In stark contrast to the total hip group, when analyzing the peri-op data for the total knees, obese patients were found to have no difference in lengths of stay and were no more likely to be charged to a rehab facility. Interestingly, both obese and morbidly obese patients were found to have lower average blood loss than their non-obese counterparts, which the authors were not able to explain. If you then combine all of these results from the two meta-analyses into one graph, it becomes immediately evident that the odds ratios for most complications are much higher for the total hip patients, as shown with the blue bars, versus those for total knee, as shown in orange, especially when isolating for morbidly obese patients, which are the lighter columns. While those two meta-analyses did not directly compare the complication profile of the total hip versus total knees, there was a retrospective review of primary total hip and total knee patients from 2010 to 2014, the American College of Surgeons National Surgical Quality Improvement Program database that did attempt to tease out whether there were differences in the effect of obesity between these two procedures. A total of 65,000 total hip and 97,000 total knee patients were identified. And interestingly, they found that obese total hip patients had significantly higher rates of wound complications, deep infection, reoperation, total complications compared to the total knee patients. And this is magnified even further for morbidly obese patients. These graphs show how much more likely each category of complication is for total hip versus total knee. The top left being total complications, the top right showing wound complications, the bottom left deep infections, and the bottom right return to OR. Most intriguing is the fact that this relationship appears to be dose dependent. As the patient's BMI increases, so too does the likelihood of having one of these complications in a total hip versus a total knee. While these data are imperfect, they were obtained in a retrospective fashion without standardized protocols. They do certainly tell a cautionary tale. And although we are aware that obesity impacts outcomes in joint arthroplasty, perhaps we should be shifting more of our attention towards total hips than total knees. A retrospective review of 6,500 primary and 1,600 revision knees from the Mayo Clinic between 2000 and 2008 sought to identify obesity's impact on costs for patients undergoing total knee arthroplasty. They analyzed the patient's hospital stays, complications, and 90-day costs by referencing the Olmsted County healthcare expenditure and utilization database for line item details of every purchase, every procedure or service billed to the patients and adjusted for inflation. The graph on the left here shows the mean and median lengths of stays by BMI category, with the solid blue and red lines referring to mean lengths of stay for primary revision total knee, whereas the dotted and dashed lines representing the means for primary and revision total knee without comorbidities and without complications, respectively. Adjusting for age and sex, every 5-unit increase in BMI beyond 30 was associated with a 0.1 day increase in hospital stay. And interestingly, underweight patients had similarly long hospital stays. However, it should be noted that since these data were recorded from 2000 to 2008, their relevance to today's patients is likely diminished as the average length of stay for total knee arthroplasties has decreased substantially across the board. On the right, the same breakdown is shown for total 90-day costs. And when they adjust for age and sex, every 5-unit increase in BMI over 30 led to a $500 difference in 90-day costs, which remains significant when adjusting for the comorbidities and complications. These costs were amplified even further for revision knee arthroplasties to nearly a $1,000 difference per 5-unit increase. And again, underweight patients also had much higher 90-day costs. So while the numbers presented in these graphs are likely significantly different today, they do make a strong case for increasing costs in obese patients undergoing arthroplasty, especially those who are morbidly obese. However, with shorter lengths of stay, different payment structures, and the inclusion of long-term complications beyond 90 days, these data would probably look much different if we were to reanalyze them now. Last year, there was a 21-question survey sent to all the members of AAHKS regarding their management of patients with obesity, and they received 640 responses, and their answers shed light on how much this really is affecting their practices. So the vast majority of surgeons reported a BMI cutoff of some sort, with 50% of them not operating above a BMI of 40 and 25% above 45. Among the types of arthroplasty, surgeons were less likely to perform a total hip in morbidly obese patient than a total knee. 50% of the responders felt that their patient volume would substantially decrease if they set their cutoff to 35 or lower, and largely among the surgeons in practice less than 5 years. Nearly 80% responded that they would consider recommending bariatric surgery prior to joint arthroplasty, and nearly a quarter said that they would always recommend bariatric surgery for a BMI over 40. 70% have a non-operative weight loss pathway that they offer to their morbidly obese patients as an alternative. And regardless of which specific interventions are taken, these responses make it clear that obesity is playing a huge role in how these joint arthroplasty surgeons are structuring their practices. Based on all the described negative effects of obesity on arthroplasty outcomes, it would seem natural to recommend preoperative weight loss prior to arthroplasty, as we've seen most joint surgeons do. However, this is not a simple task, and its effects on outcomes are not entirely clear at this point. By the time many of these patients even present to the office, they already have substantial pain from their arthritis with limited activity levels, thereby leading to more weight gain and potentially worsening arthritis. Additionally, they may require clearance from their medical doctor to even consider starting an exercise program. Then, even if the patients are able to lose a meaningful amount of weight preoperatively, the effects aren't all good. The best effect may be that weight loss can slow the progression of their arthritis, so if started early, can eliminate the need for arthroplasty entirely. However, while the surgery becomes technically easier with weight loss and the patients may be better able to mobilize postoperatively, a hypocaloric diet preoperatively puts the patient in a catabolic state that could put them at increased risk for poor wound healing and infection, which are some of the same complications that the obese patients are at risk for. Further complicating matters is the paucity of data on patients who lose a substantial amount of weight non-surgically prior to arthroplasty, as this is a relatively uncommon feat. One study examined a cohort of over 10,000 total knee patients and found that 12% lost more than 5% of their body weight in the year before surgery, and there were no differences in surgical site infection or readmission in those patients. So despite the limited evidence that preoperative weight loss improves outcomes in joint arthroplasty, bariatric surgery has frequently been implemented as a pre-op measure for obese patients indicated for total joint arthroplasty. However, the existing literature on this topic is largely retrospective in nature and has conflicting results. A 2019 study from China retrospectively analyzed their hip and knee arthroplasty database from 2006 to 2014 and created the graph shown here. It shows that despite the steady increase in the proportion of arthroplasty patients who are morbidly obese and the documented risks of operating on these patients, the proportion of these patients undergoing bariatric procedures did not change during this time. While this is not the most current data, it shows that at least up until 2014, Chinese arthroplasty surgeons overall were not recommending bariatric surgery any more frequently than before. A similar study from the New York statewide database in 2020 also assessed the incidence of bariatric surgery prior to joint arthroplasty, but they stratified their results by patient age. And contrary to that Chinese study, they found that there was a modest increase in the incidence of bariatric surgery prior to arthroplasty overall, as shown by the purple line here. However, the group of patients between 20 to 44 years saw almost no increase, while the group of patients 45 to 64 years saw nearly 20-fold increase in bariatric procedures. They also showed that the overall incidence of bariatric surgery, irrespective of joint arthroplasty status, increased nearly 15-fold during the study period, meaning that the increase in arthroplasty patients undergoing bariatric surgeries may at least be in part explained by the overall increase in bariatric procedures in the general population during that time, rather than by direct recommendation from their surgeon. So based on these data on the previous slides, it's not clear if the proportion of morbidly obese patients being recommended to have bariatric surgery prior to arthroplasty is increasing, but nonetheless, the number of arthroplasty patients having bariatric procedures is going up. With this in mind, we can start to analyze the existing evidence for both for and against bariatric surgery prior to arthroplasty and understand some of the limitations in its interpretation. So we can start out with some of the studies that have shown better outcomes. In 2015, this is a study out of UVA. They used a national database to compare 90-day post-op complication rates between patients who were not obese, morbidly obese without bariatric surgery, and morbidly obese with preoperative bariatric surgery prior to total knee arthroplasty. Overall, there were 66,000 non-obese, 11,000 morbidly obese without bariatric surgery, and 219 with bariatric surgery. Major complications included DVT and PE, post-op infection and need for IND, acute MI, respiratory failure, and CVA, while minor complications were stiffness, UTI, pneumonia, acute renal injury, acute cholecystitis, and need for transfusion. The morbidly obese patients who did not undergo bariatric surgery were at much higher risk for every complication category within 90 days from surgery compared to non-obese patients. However, while those who underwent bariatric surgery were still at increased risk of most complications compared to non-obese patients, they did have reduced rates of minor and major complications, infection, and medical complications within 90 days compared to those who did not undergo bariatric surgery. Despite the results that support bariatric surgery prior to total knee arthroplasty in this study, it does have several limitations. First off, being from a database, while this is convenient, it limits the homogeneity of the cohorts. And similarly, the demographic data in this study show that the groups were not all similar at baseline, with the bariatric group having significantly younger age and differences in smoking and comorbidities pre-op. Additionally, the limited study period of 90 days limits their ability to detect long-term complications like chronic PJI, aseptic loosening, and implant failure. Another study used the New York statewide database to compare morbidly obese patients undergoing arthroplasty over a 14-year period. They propensity matched 2,600 bariatric and morbidly obese total knee and 800 total hip patients. They found no difference in revision rates between any of the groups, although the bariatric patients who required revisions demonstrated a longer time to revision by nearly a year, which the authors felt could be related to the development of metabolic bone disease in these patients. There were also no differences in prosthetic hip dislocation or periprosthetic fractures between the groups. However, they did note that lower risks of in-hospital complications for bariatric patients undergoing both total hips and total knees, and risks of 90-day complications were lower for bariatric total knees. While this study seems to come to similar conclusions to the prior one, it does suffer from some of the same limitations, and that is a retrospective analysis of a database group. Additionally, they did not report on the length of follow-up for the patients, and when they stratify their analysis by complication type, they only found differences among the hips and CVA rate and among the knees and post-op infection rate. In 2016, there was a retrospective matched cohort study from the Mayo Clinic that compared a group of 47 total hips undertaken following bariatric surgery with 94 that did not have bariatric surgery, with an average follow-up of 3 years. The average time to hip replacement for the bariatric surgery was 5 years and ranged from 4 months to 12 years, during which the average BMI dropped from 50 to 35. The baseline characteristics for the comparison group were all similar to those with the bariatric group. And it should be noted that not all of the procedures were performed via the same approach, with 2/3 being posterolateral, a quarter anterolateral, and only a few direct anterior. Overall, the study found that patients who had not undergone bariatric surgery were much more likely to require reoperation and revision, with only 70% and 80% being reoperation and revision free, respectively, at 5 years. There was also a trend towards more PJIs in the comparison group. The most common reason for reoperation was PJI in both groups. However, it should also be noted that there were 5 revisions for dislocation in the comparison group and none in the bariatric group. These results imply that bariatric surgery prior to total hip arthroplasty greatly reduced the risk of long-term major complications, and the long-term follow-up and matched comparison group helped to validate those results. However, this is limited by the small retrospective cohort size, variations in the approaches, and wide range of time between the bariatric surgery and the hip arthroplasty, as well as a lack of data on any other complication types. So now we can take some time to explore the studies that have reported either worse or equivocal outcomes. The same group from the Mayo Clinic that demonstrated significantly better revision and reoperation rates in total hip patients following bariatric surgery also reported on their experience in total knee patients, and the results were less positive. Similar to their prior study, there was a retrospective matched cohort. However, there were 2 comparison groups, including one with a high pre-op BMI averaging 51 and one with a low pre-op BMI averaging 37. The average time to knee replacement from bariatric surgery is 4 years, ranging from 4 months to 11 years, during which the average BMI dropped from 51 to 37. The baseline characteristics for the groups were all similar, except for the bariatric group being slightly younger, and the average follow was 4 years. The study found that there was an increased risk of reoperation in the bariatric group compared to both the high and low BMI groups, and there was significantly worse 5-year survival for reoperation. The bariatric group was more likely to undergo revision compared with the low BMI group, but not the high BMI group. The most common reason for reoperation was stiffness in all groups, and there were no differences in total complications or PGI between any of the groups. So the authors hypothesized that the difference in reoperation rates may be due to an overall higher threshold to reoperate for stiffness in the morbidly obese patients. The study benefited from having 2 different comparison groups, but again was limited in its small retrospective cohort size and a very wide range of time between the bariatric surgery and knee arthroplasty. A multi-center retrospective cohort study utilized the Medicare hospital claims data to identify patients who underwent bariatric surgery following total knee and compared their 90-day outcomes to a group of all total knees and a group of patients with BMIs over 40 who underwent total knee without bariatric surgery. The bariatric group in this study showed markedly elevated risk in most complications examined compared to total knee patients, and there were differences between the types of bariatric surgery performed, including a higher rate of implant failure after gastric bypass compared to other types of bariatric surgeries. However, when you were to compare the bariatric group to a similar group of morbidly obese patients who did not undergo bariatric surgery, the differences are much more subtle. Despite the bariatric group having higher hazard ratios for death, implant failure, and pneumonia, some areas actually showed marked improvement in the bariatric group. Dislocation, pulmonary embolism, revision, renal failure, and wound dehiscence were all found to be less frequent in the bariatric group, although p-values were not supplied. The authors of the study attempted to spin this as a sign that bariatric surgery is dangerous prior to total knee arthroplasty. However, their most worrisome data comes in comparison to all total knee patients, while their comparison to morbidly obese patients is far less startling and in many areas shows reduced risks. Additionally, they had limitations, including the fact that this only included Medicare patients over 65, did not have BMI data, there is no mention of statistical analysis, and a vast majority of bariatric patients were listed as procedure unknown. Meanwhile, a group from Duke performed a review of all patients from the Medicare database to identify 6,000 patients who underwent total knee arthroplasty after bariatric surgery and compared them to 26,000 morbidly obese total knee patients and 6,500 normal BMI patients with a minimum follow-up of 2 years. Due to constraints in the Medicare database, they couldn't produce matched cohorts, and thus the bariatric group was significantly younger and had higher incidences of anemia, cardiovascular disease, pulmonary disease, liver disease, polysubstance abuse, psychiatric disorders, and smoking than the other two groups. So they found that the bariatric group had a higher risk in every 30-day medical complication category at 90 days. But at 90 days, the bariatric group had higher rates of revision, extensor mechanism, rupture, and manipulation than the morbidly obese group. At 2 years, the bariatric group had significantly higher rates of PJI, revision, manipulation, and extensor mechanism rupture than both other groups. So despite the very large cohort size and breakdown complications, this study suffers because of the large baseline differences in medical comorbidities between the groups. We also don't know anything about the surgical approaches or techniques, and there's a lack of data on time from bariatric surgery to arthroplasty. Perhaps if they had been able to match the cohorts by their baseline characteristics, the results could have been much different. Earlier, we saw 2 database studies that showed slightly better complication profiles for bariatric total hip patients, but their limited follow-up and heterogeneous patient populations left their conclusions without much weight. This review of patients from the Medicare database from the same group as the prior knee study sought to challenge that. They identified 1,500 patients who underwent total hip after bariatric surgery and compared them to 7,000 morbidly obese patients and 3,700 normal BMI patients with a minimum follow-up of 2 years. The rates of PJI, revision, and wound complications were all similarly elevated in the bariatric and morbidly obese groups compared to the normal BMI group, both at 90 days and 2 years, with even greater risks at a 2-year time point. Interestingly, although the risk of dislocation was higher for the bariatric and morbidly obese groups, only the bariatric group had a higher dislocation rate at 2 years, and by a large margin. The risk of medical complications within 30 days of surgery was higher in both the bariatric and morbidly obese groups in categories including acute MI, heart failure, pneumonia, acute renal failure, and UTI, but the rates of DVT and PE were notably similar between the groups. This study had similar strengths and weaknesses to the prior study in the knee population. The authors theorized that the high dislocation rates in the bariatric group could be related to ligamentous laxity and abnormal collagen deposition in these patients. However, it's difficult to accept these complications at rates as facts due to their significant limitations in their study design. And again, perhaps if they had been able to match these cohorts by baseline characteristics, they could have seen much different results. Another database review from China in 2019 sought to evaluate the inpatient outcomes of bariatric patients undergoing hip and knee arthroplasty compared to morbidly obese patients. What distinguishes this from the prior studies that we looked at is that they display the results both before and after matching their cohorts by their pre-op characteristics and comorbidities, as well as their mortality risks. They identified 2,500 hip patients with bariatric surgeries and compared them to 2,500 morbidly obese patients, and then 9,800 patients for the knee groups. Formula A represents groups that are matched only by gender, age, income, primary payer, and race. And Formula B matches those same categories plus mortality risk and 27 different medical comorbidities. Prior to matching for comorbidities, the bariatric total hip patients were found to be more likely to have a PE, blood transfusion, and anemia, and had a slightly shorter length of stay. After comorbidity matching, though, only the differences in transfusion and anemia persisted. The results for total knees were similar. Prior to matching for comorbidities, the bariatric total knee patients were found to be more likely to have a PE, blood transfusion, anemia, but had a slightly lower risk of respiratory complications, death, and shorter length of stay. But after matching for the comorbidities, the PE risks were similar and the difference in mortality was cut in half. This study was limited in that it was also retrospective and lacked data on approaches and time from bariatric surgery, but it also looked at inpatient medical complications and did not evaluate any surgical complications. However, it shows that it's important when evaluating these patients to match their baseline characteristics to their comparison groups, because after matching for comorbidities in these patients, the inpatient outcomes between the bariatric and morbid obesity groups were very similar. Just this past February, another group from the Mayo Clinic published on their outcomes in bariatric total knee patients in JOA. They retrospectively identified 205 bariatric patients who subsequently underwent a total knee and matched them to 205 patients with a BMI under 40 and 205 patients with a BMI over 40 who underwent total knees and had similar ages and comorbidities at baseline. Their study period was nearly 30 years, from 1992 to 2020. The bariatric group had a mean time of 11 years from their bariatric procedure prior to their arthroplasty, which ranged from 3 months to 44 years. The average BMI in the other two groups was 44 and 32 respectively. And after matching, there was 300 patients with at least 2-year follow-up. They found that 10-year survivorship free of revision was 74% in the bariatric group versus 92 in the low BMI and 95 in the high BMI groups, with infection and instability being the most common reasons for revision in the bariatric group. 10-year survivorship free of any reoperation was 65% in the bariatric group versus 84% in the low BMI group and 93% in the high BMI groups. As seen in table 2 here, reoperation for instability and infection were significantly more frequent in the bariatric group. There were not enough events to test for a statistical difference in any of the individual complications within 90 days of the surgery, but the total complication rates were not significantly different. There were 68 bariatric patients who still had BMIs over 40 at the time of their arthroplasty, but they had no significant differences in outcomes when compared to the other bariatric groups. When dividing the bariatric group based on time before arthroplasty, it was found that there was no difference in rates of any reoperation, but there was patients with more than 2 years between their procedures had a higher risk of any revision surgery with a hazard ratio of 11. The authors also compared Roux-en-Y to sleeve gastrectomy and lap band and found no difference in reoperation or revision rates based on the type of bariatric procedure. They did note that Roux-en-Y was much more popular prior to 2012, with sleeve gastrectomy being more popular after 2012. Despite the retrospective nature of this study, their study design and analyses are probably the most robust that I came across for this subject, and their cohort sizes are fairly substantial. They are also the first to stratify by bariatric procedure type. The majority of their data points point to worse rates of revision or reoperation in bariatric patients, which is troubling for us. One other interesting finding is that the low BMI group actually had worse outcomes than the morbidly obese group, although they did not provide any statistical comparison between them. Some other limitations include their extremely long study period of nearly 30 years and lack of power to detect any differences in the individual complication rates. In addition to assessing the overall efficacy of bariatric surgery prior to arthroplasty, there have been multiple studies that have attempted to determine the optimal timing of the two procedures relative to each other. A retrospective study from Wisconsin identified 36 patients who had joint replacements before a bariatric procedure and 66 who had joint replacements after a bariatric procedure and compared their short and long-term outcomes. The first group had their arthroplasty performed an average of 5 years before bariatric surgery, while the second group had theirs an average of 4 years after bariatric surgery. and the average BMIs at the time of arthroplasty were 37 and 43 respectively. 90% of the bariatric procedures were Roux-en-Y bypass. The post-bariatric surgery group had a shorter operative time and length of stay, but there were no differences in early or late complications. And interestingly, the post-bariatric group was more likely to be sent to a rehab facility. Despite the differences in OR time and length of stay, there were no differences in 30-day or long-term complications between the groups. However, the average follow-up duration was much longer in the pre-bariatric surgery group at 9 years versus 3 years. So the study was helpful in that it compared similar patients who had their bariatric surgeries at different points relative to their arthroplasty. However, it was a small retrospective cohort with a lack of distinction between hip and knee, differential follow-up lengths, and a variable amount of length of time between the bariatric surgery and arthroplasty. Meanwhile, a group from HSS performed a retrospective cohort study from the Premier Healthcare Claims Database to identify patients who underwent both bariatric surgery and joint arthroplasty within 5 years of each other over a 13-year period. Overall, they found 1,900 patients who underwent bariatric surgery before arthroplasty and 1,000 who underwent arthroplasty before bariatric surgery. In the graph shown here, the black lines represent patients undergoing total hip or knee prior to bariatric surgery, and the dotted lines represent patients undergoing total hip or knee after bariatric surgery. The timescale on the x-axis shows how far apart the two surgeries were. Unlike the previous study, they found that patients undergoing arthroplasty first were more likely to have major complications, including acute renal failure, MI, sepsis, PE, pneumonia, and central nervous system events with an odds ratio of 4.8. This major complication rate was highest in patients who underwent bariatric surgery within 6 months after their arthroplasty. The patients who had their arthroplasty prior to bariatric surgery similarly had higher rates of ICU admission, ventilator use, 30-day readmission, and 90-day readmission. And in general, the complication rates were much better in both groups when the two surgeries were removed from each other further apart, and worse when they were within 6 to 12 months of each other. So this study appears to show that medical outcomes are superior when you perform the bariatric surgery prior to arthroplasty versus the reverse of that. And that surgeons should avoid scheduling these procedures within 6 to 12 months of each other. However, we do not know much about the patients that were pulled from this database, and we have no additional information regarding surgical complications. A group from Minnesota reviewed their bariatric total knee patients from 1996 to 2008 and divided them into 3 groups based on the timing of their surgeries. Group 1 had 39 patients with total knees before their bariatric surgery. Group 2 had 25 who had their total knees within 2 years after bariatric surgery. And group 3 had 61 patients with total knees more than 2 years after bariatric surgery. Their objective was to identify differences in the perioperative complication rates between these groups. Group 1 had not yet had their bariatric surgery yet, so naturally had a higher BMI at the start than the other groups, but similar lengths of hospital stay. They found that the group that had their bariatric surgery more than 2 years prior to total knee had significantly shorter anesthesia time, OR time, and tourniquet time than the other 2 groups. The 90-day complication rates and transfusion rates were not significantly different, and the study was not powered to detect differences in individual complication types. There were 2 revisions in group 1, none in group 2, and 5 in group 3, although there was no statistical difference in these. Like the previous study, this one showed that patients who had bariatric surgery more than 2 years prior to total knee spent less time in the OR, presumably due to easier surgical technique after the weight loss. However, this study was also retrospective and not powered to detect differences in individual complications. Thus, they were not able to make any definitive conclusions regarding whether one group showed a superior complication profile. A retrospective review of patients from the Healthcare Cost and Utilization Project database in California identified patients who underwent total hip and knee arthroplasties following bariatric surgery and divided them by whether their arthroplasty was more or less than 6 months after their bariatric surgery. And then they compared their 90-day complication and readmission rates. They found 330 hip and 1,000 knee cases with no significant baseline demographic differences in the groups based on that 6-month cutoff. The patients undergoing total hip more than 6 months after bariatric surgery were less likely to be readmitted. There were no differences in overall 90-day complications. However, female patients were more likely to have complications than male patients in both cohorts. And then based on these findings, the authors concluded that it may be best to avoid bariatric surgeries within the 6 months preceding a hip replacement. So whether or not bariatric surgery is an efficacious method for weight loss prior to arthroplasty, the costs of such procedures and their expected cost savings must also be addressed if we are going to continue to recommend them. A group from HSS performed a state transition Markov model to simulate the cost utilities of immediate total hip arthroplasty compared to total hip arthroplasty 2 years after bariatric surgery for morbidly obese patients. They attempted to gather data from the literature on utilities associated, costs, probabilities for various outcomes and complications that would affect direct and indirect costs over a 40-year period. When they plugged all the numbers into their simulation, they found that the bariatric protocol led to an average cost savings of about $1,000 and a gain of about 1 quality adjusted life year compared to the total hip alone group. The incremental cost effectiveness ratio, which is the difference in cost divided by the difference in quality adjusted life years, showed that the total hip alone protocol was dominated by the bariatric protocol. Unfortunately, while this is a very complicated simulation and a great experiment, it was severely flawed. Not only did the costs depend on the quoted hazard ratios reported in the literature that are far from guaranteed, but they didn't include any outcomes from actual bariatric patients that underwent total hip. And for these reasons alone, it's hard to put much weight in their absolute numbers. The same group performed a similar analysis for total knee patients and found that the bariatric protocol led to an average additional cost of about $24,000 and a gain of 2 quality adjusted life years. The incremental cost effectiveness ratio, which again is the difference in cost divided by the difference in quality adjusted life years, showed that the bariatric protocol cost about $14,000 for each additional quality adjusted life year. The authors felt that this showed that it's a cost-effective option for improving outcomes in these patients. However, it suffers from the same limitations as the prior simulation. So let's try to put this all together. There was a group from China that performed a meta-analysis a few years ago that identified 9 studies with nearly 40,000 patients over the past decade that evaluated the efficacy of bariatric surgery prior to joint arthroplasty, most of which were reviewed in this talk today. This included 5,700 patients who underwent bariatric surgery prior to joint arthroplasty and 33,000 morbidly obese patients who did not. In the short term, they found that medical complications, length of stay, and OR time were significantly less than the bariatric group. However, there is no difference in venous thromboembolic events, PJI, or superficial wound infections. The only short-term difference was when dividing total knees and total hips. There was a slightly less likelihood of having a short-term PJI in the knees. In the long term, there were no significant differences in PJI, periprosthetic fracture dislocation, or revision between the bariatric and morbidly obese group. There were also no long-term differences when dividing total knees and hips. And overall, this meta-analysis did a good job consolidating all the data that we've seen for these patients. However, the quality of the meta-analysis is fully dependent on the quality of the studies that it analyzes. And unfortunately, the quality of the studies included in this meta-analysis was overall poor, which only gets multiplied further when you're combining and reanalyzing all the data. Furthermore, the study design parameters of each included study varied substantially, and not all the studies reported on each complication type. Regardless, the results were not very conclusive. So if the outcomes of bariatric surgery prior to joint arthroplasty are to remain uncertain at this point, this begs the question of whether there are any suitable alternatives. If obese patients present early on in the development of arthritis, bariatric surgery can also be utilized as a tool in eliminating the need for arthroplasty entirely. These procedures can be chondroprotective via a combination of decreased secretion of adipose cytokines and reduced joint contact forces and improved posture and gait. Multiple studies have suggested that bariatric surgery leads to decreased pain, increased activity levels, increased range of motion, improved radiographic appearance of osteoarthritis, and even potentially a resolution of arthropathy. There's one study of 64 patients who underwent bariatric surgery who noted a 0.65 millimeter increase in medial joint space on AP X-rays at 3 months follow-up. That was associated with an increase from 78 to 90 on the American Knee Society scale. Although these benefits suggest that ultimately, if successful, bariatric surgery could be best implemented to prevent progression of arthritis rather than as a means to improve outcomes with arthroplasty. When behavioral and diet changes are insufficient for weight loss and bariatric surgery is to be avoided for any reason, there are multiple pharmacologic weight loss options approved by the FDA, including orlistat, phentermine, naltrexone, bupropion, and injectable liraglutide. Among these, orlistat remains the most commonly used with a tolerable side effect profile and minimal effect on protein uptake. However, despite the relatively large amount of data that we have on these drugs for weight loss, there remains no evidence in their use prior to joint arthroplasty. Many patients who are obese have been on strict diets or have decreased caloric intake following bariatric surgery are found to be in a hypoalbuminemic state. In many surgical specialties, hypoalbuminemia has been shown to increase risk of complications post-op. One study also found that patients undergoing total hip were at increased risk of perioperative complications, including cardiopulmonary complications, systemic infection, and total complications. Though it's likely to help, hypoalbuminemia can have adverse effects on surgical outcomes. There remains little evidence on when and how to replace it. Within the orthopedic literature, there's currently no data, and the existing data in critically ill patients is conflicting. And moreover, there are multiple modalities for correction, including IV albumin, parenteral nutrition, enteral protein supplementation, none of which have been shown to be superior to the other. And as such, this remains an area of potential future research in arthroplasty. So now we can revisit our cases. The first was patient RG, 60-year-old male, BMI was 61 and improved to 42.8 with Weight Watchers, lost 160 pounds. He underwent a total knee arthroplasty in the left knee without any further weight loss prior to it. He did have a UTI postoperatively, which resolved uneventfully, and he otherwise recovered appropriately and just had the other side done. Patient MS was a 72-year-old female with a past medical history, and her BMI went from 56 to 39 after a gastric sleeve. She also underwent a right total knee and recovered without any issue. This is our patient, our 58-year-old female who had her gastric bypass complicated by a stoma dehiscence and gained back much of the weight. Many of us have recommended that she find a way to lose more weight before we undergo arthroplasty. However, she underwent it at the BMI that she had and was still unable to get her stoma revised, but she recovered well without any issues. And then the last patient was AR, who was the 68-year-old male who had bilateral knee pain for 20 years. His BMI went from 57 to 46 after his recent bypass. And we asked how long everyone would wait prior to a total knee arthroplasty. At this point, it's been 18 months and he has not yet had his arthroplasty, so TBD. In conclusion, there's still much we don't know about regarding the risks and benefits of bariatric surgery prior to total joint arthroplasty. This is a patient population that's becoming a larger and larger proportion of our primary arthroplasties and even more of our revisions, but we still have very few options to reliably improve their outcomes, leading to an overall unwillingness of providers to treat them and insurance companies to pay for their care. Unfortunately, we currently do not have an adequate evidence base to combat these issues, as so much of the existing data is of low quality with inconsistent conclusions. In addition, many of the article titles have broad generalizations designed to grab the reader's attention without actually having a solid basis for their claims. Aside from the low quality data for bariatric surgery, patients' access to bariatric surgery when it is suggested is also extremely limited. One study found that 80% of patients with a BMI over 40 and end-stage arthritis who were required to lose weight prior to joint arthroplasty remained morbidly obese and never underwent their arthroplasty. And if the questionable indications and limited access to bariatric surgery weren't enough, we have almost no data for non-operative interventions like pharmacologic weight loss and albumin replacement in this population. So this means that we still have a lot of work to do in order to establish the best strategies for safe arthroplasty in this population and increase access to those interventions. Moving forward, more high-quality prospective studies on the effects of bariatric surgery on arthroplasty outcomes are needed. Ideally, those studies would stratify patients by pre-op BMI, type of bariatric surgery, duration before total joint, and stratified by hip versus knee. These studies also lack any patient-reported outcome measures, which could provide additional insight beyond the complication rates. Additionally, including unicompartmental arthroplasties would improve our understanding. There's one promising study, the so-called SWIFT trial, which has been prospectively recruiting patients since 2016 and seeks to examine the potential of bariatric surgery prior to total knee arthroplasty to improve peri-op and long-term outcomes, as well as the ability to delay or even negate the need for arthroplasty. And that one's estimated to finish recruitment by next year. Beyond bariatric surgery, there's still many questions regarding pharmacologic weight loss and pre-op correction of hypoalbuminemia, both of which could prove to be powerful tools in the treatment of this population. So thank you everyone for being here today. If anyone has any questions, I'd be happy to answer them. I'd like to thank Dr. Kairos and Dr. Harwood for all their help.
Well, thanks, Todd. I thought that was very comprehensive, a little depressing, but comprehensive. And you know, unfortunately, it's still a problem that is not only exists, but is getting worse. You know, obesity in the population isn't coming down anytime soon. For whatever reason, it's become an epidemic. And now there's, you know, some woke social pressure to declare morbid obesity the new healthy, which isn't helping anything. But I think when you look at the cases, I think that the decision point, you might have picked the wrong spot. Because when we see these patients in the office, we do have a decision point, but it's usually not after they have bariatric surgery or they lost 100 pounds in Weight Watchers. The decision point's usually when they come to the office. And let me tell you something, it's very, very, very difficult to deal with these people. You know, they've been heavy all their lives and they come in and now they hurt in their knees the first time or hips for the first time. And they come into you and then you're looking at them and you have a binary choice. You either operate on them or you don't operate on them. If you don't operate on them, then many of them will not be happy. And not happy to the point where they'll go on social media and they'll do other things, or they'll go on your website and give you like negative reviews because you didn't do what they wanted you to. So it's like walking on eggshells. Every time I go into a room with a morbidly obese patient, I mean, I'm not judgmental, but literally we have to make a decision whether we're going to risk doing surgery on these people. And if you don't, you know, then what do you do? Do you refer them to a nutritionist? Do you refer them to a surgeon? And that's even tricky because they come into you because they can't walk and their knee hurts. And then you're like, well, you do need surgery, but it's not the knee replacement you need, it's bariatric. And that doesn't always go over well either. So it's a very difficult job to handle these patients. And most of the time, you know, we kind of split the difference. I try to gently encourage them to consider weight loss or go to bariatric surgery. There is a little bit of leverage that you have that, you know, sometimes works, like the Weight Watcher guy, which was my patient. But that's rare. And then, by the way, every single one of these patients, the dogma that they're going to lose weight after a knee replacement, that dogma doesn't come from us. Because we all know that doesn't happen. That dogma comes from every single patient that walks into your office that's heavy. They're like, oh, doc, you know, I could lose weight if I could only, like, you know, walk again. I'm like, yeah, okay, not really. So I don't know, at this point, I can tell you that I still try to send them to our bariatric friends. I think they do a very good job. And if nothing more, after the bariatric surgery, the orthopedic surgery is slightly less technically demanding. So if nothing more, you know, then that helps with that situation. And the difference between knees and hips dislocate. I don't know why they dislocate more after bariatric surgery. Maybe there's some soft tissue laxity that occurs, but I really can't explain that because that should actually be better since it's a little technically easier to do the case. With knees also, you know, people have distribution of weight differently. So some people can be morbidly obese, but then you look at their knees and they're heavy, but they're not crazy heavy. Whereas almost always the hip, either from the front, the side, or the back, the hip's heavy, so no matter what, it's difficult. Anyway, it was a great talk, and you know, it's depressing and still a challenging situation. So thanks.
Thank you. Do you or Dr. Kairos have a cutoff for how long after a bariatric surgery you want to wait before your arthroplasties?
It's usually about a year, but it takes them about that long to lose the weight. And then the details of whether, you know, it's safer or not, it seems like the waters are pretty muddied. But while they're still in the active weight loss phase, I don't think, you know, in a catabolic phase, it just doesn't make a lot of sense to do it during that time frame. But I don't have any data any more than you already showed. So that's kind of what our strategies are.
I agree with everything that Dave said. It's a great talk. You know, this is a very challenging and big problem that's only getting bigger, no pun intended. I do think that first visit is the most challenging visit, and I do think that you know, I think that, you know, each patient has to be approached. It's a case by case basis. It's not like, you know, all patients with a BMI of over 40 are the same. You know, there are patients who are clearly not surgical candidates, and then there are patients who are, you know, not, you know, that far away from, like, you know, being able to get a joint replacement. So I think it's a case by case or a patient by patient approach. It's a problem. It's definitely a problem. And I think that this talk illustrates that I don't think bariatric surgery is certainly not a panacea for this problem. You know, on our side, I mean, we have some tricks that we can, you know, employ to try to minimize the risks that these patients have, you know, after surgery with extended antibiotics and wound vacs. But again, I think we're far away from. There's still, as you said, there's still a lot of work to do.
I just want to ask about the total joint surgeons and Dave, Steve, I like to know what you think, but in mid-2022, you guys are beholden to 90-day complication rate because of bundled payments, CJR, whatever the case may be. So, I mean, how do you think this affects that perspective, affects your approach towards these patients? Because if these are at-risk patients in terms of, you know, busting the bundle, so to speak, you know, how do you handle that?
Yeah, I mean, that certainly makes it even more challenging to want to operate on these patients, because you know that there's a much higher risk of that happening. I personally haven't had to deal with, you know, walking that rope, but I'd be curious if Dr. Harwood or Dr. Kairos have felt like that's affected their willingness to do these procedures.
Was the question regarding bundle payments? Is that?
Steve,
I couldn't hear it very well.
You can't hear me.
Yeah, that's correct. Dr. Guy was asking if.
Yeah, well, I think it's, you know, I could tell you from our experience, you know, we entered, you know, BPCI or, you know, bundled payments, you know, back in 2016 on our side. And, you know, there was definitely, you know, motivation to not indicate these people for surgery. Now with CJR, which is basically the onus is on the hospital. So, you know, I can bring a patient, you know, to the operating room, and if something happens, you know, me personally, I'm not going to get dinged, but the hospital may get dinged. And so I think, you know, some hospitals I know have strict BMI cutoffs. And if you have a BMI greater than, you know, X for, you know, 40, they will not, you know, you cannot bring that patient to that hospital for surgery. I'm pretty sure that they're doing it at HSS to some extent. I'm not sure if they're doing it at Rothman, but I mean, I think that that's probably coming down the pipeline. I mean, currently Horizon will not approve joint replacement if a patient has a BMI greater than 40. So, you know, there are many, so then, you know, those patients, you know, it's a very easy conversation because now you basically just blame it on the insurance company. you know, but I mean, obviously it's not that black and white, but you know, you talk to them about the increased risks and the rationale behind it. But at least, you know, if the mandate comes from someone other than us, it's a little bit of an easier conversation because it's not, then it doesn't come across like that we're the bad guys.
All right, well, thank you, everyone. I think that's it for us.